Good morning. I would like to welcome everyone to the MD Anderson Cancer Center series, Enjoy Science. This is a series of seminars given by MD Anderson faculty members and organized by the Office of the Chief Scientific Officer, Dr. Giulio Draetta. My name is Alessandra Ferraioli, and I have the pleasure of hosting this series with my colleague, Dr. George Kalin. The goal of Enjoy the Science initiative is to strengthen the connection between the scientific and medical community at the MD Anderson Cancer Center and our colleagues, our patients, and our friends around the world during this time of limited in-person, at the bench, and in the clinic activities. Today's seminar is being recorded and will be made available on the Enjoy Science website later this week. It is my great pleasure to introduce the speaker of today. It is Dr. Arlene Sicker-Radke. Dr. Sicker is a professor in the Department of Genitourinary Medical Oncology in the Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center. Dr. Sicker is a world-known expert in the treatment of urothelial cancers and has conducted pivotal studies on targeted therapy of bladder cancer. She will be discussing for us the very interesting topic of personalized therapy with the erdafitinib, the first biomarker-targeted therapy for urothelial cancer. So without any further delay, I give the microphone to Dr. Sicker. Thank you.
Oh, thank you very much, Dr. Ferrajoli. And it really is an honor to be invited by Dr. Ferrajoli and Dr. Kalin, and especially when I look at the other group of presenters that they have assembled for this seminar series. It really is my honor to be here today. So I'll be talking about our experience developing personalized therapy with erdafitinib, which is the first biomarker-targeted therapy for the treatment of metastatic urothelial cancer. And here are my disclosures. We do work with pharmaceutical companies in order to make these developments. But what we have been learning about bladder cancer is that bladder cancer is no longer just one disease. It's actually composed of multiple diseases which differ in their underlying biology and differ in their mutation patterns which play a role in this biology. And FGFR3 is one of these mutations which appears to play a role not only in how these tumors may behave, but also in how they develop. When we look at early research in bladder cancer more than 10 to 15 years ago, we already had a sense that bladder cancer was not just one disease. If you look at data on the left in a paper by Colin Dinney, we had seen this dual track concept of how urothelial tumors arise, with the majority of tumors arising along this papillary pathway, where essentially tumors proliferate and grow in this stalk-like pattern, and then over time develop the additional mutations that are associated with developing into an aggressive invasive disease that kills. We also saw a group of tumors that de novo appeared to have this very aggressive phenotype, and we saw carcinoma in situ as one of the earliest elements, suggesting those tumors with CIS had a high propensity to develop into the invasive tumor that kills. We also saw a lot of genetic instability in RB and P53 abnormalities along this non-papillary pathway. We also see data provided by Maggie Knowles looking at the frequency of FGFR3 mutations associated with the urothelial cancer. And what's interesting to note in this separate paper, it almost follows a similar format where we see early evidence of FGFR3 alterations arising in 26% of tumors that are hyperplastic, and the highest frequency overall are in these papillary low-grade, low-stage disease, with FGFR3 mutations present in over 60% of patients. However, only a small percent of these tumors transform into the invasive disease that kills. And over time, about 15 to 20% of metastatic tumors will harbor FGFR3 alterations. Looking at gene expression profiling, our group at MD Anderson was able to develop insights into the different subtypes of urothelial cancer. And interestingly, we saw a lot of this luminal basal variant histology akin to what was observed in the breast cancer TCGA data. At the time this data was being developed, not only at MD Anderson with David McConkey and Woon-Young Choi, we saw evidence of several other groups, the Lund group, a group at UNC, and the bladder cancer TCGA, all separately showing these luminal and basal features. When we started to look further at these types of features with gene expression profiling, we also started to see evidence that we could use this to differentiate tumors that differ in their underlying prognosis, and we saw early hints that these could help predict benefit from treatment. And when we looked at some of the early data published by Choi and McConkey when they were at MD Anderson, looking at a group of tumors that were muscle invasive, we saw that this basal subtype shown by the curve in red had the worst overall clinical outcomes. And this was a group of patients who really did not have much in the way of treatment. When you compare that to luminal and P53-like tumors, which appeared to have better prognosis. And this was seen in other groups as well. We then applied the same gene expression profiling to a group of patients that we had treated on two separate neoadjuvant clinical trials, a trial of dose-dense MVAC with bevacizumab and another trial treated with MVAC neoadjuvant chemotherapy. And in two different groups, we saw that this chemotherapy-naive group of tumors that did quite poorly when they had basal features and very high proliferative rates actually did the best overall, with the best overall survival when treated with neoadjuvant cisplatin-based chemotherapy. And this led us several years ago to make the first predictions that perhaps bladder cancer, not being one disease, could start being separated into different types of tumors, some that appeared more basal, like that triple negative basal breast cancer, which has more of the chemosensitive signatures. We also saw these luminal tumors, and intriguingly, that is where we saw the FGFR3 signature enriching. In fact, at the time we were doing our original gene expression profiling studies, we were also enrolling patients onto some of our earliest immunotherapy trials. And as I was treating patients, I noticed that several of my patients with FGFR3 alterations did not appear to be responding to an immune checkpoint inhibitor. So I went back to David and I said, David, these tumors just don't appear to be responding. Why might that be? And when we looked at the gene expression profiles of these tumors based on a variety of immune markers, we saw that there were groups of tumors that appeared immunologically cold. There was a group of tumors that appeared very hot with very high levels of immune markers. And then we hypothesized there might be a group of tumors that were just right. They had the right immune markers showing immune cells were going in that maybe would reflect the best treatment to an immune checkpoint inhibitor. Intriguingly, when we look at FGFR3 alterations, we see high enrichment for amplifications, mutations, and fusions of these FGFR3 markers in the immunologically cold subset of urothelial cancer, perhaps accounting for some of the lack of response or benefit that I had seen in our small patient population. It's also possible that these gene expression profiling might tell us a bit about where the tumors are rising along the urothelium or just about their clinical behavior. And when we look at the basal markers with a lot of P63 expression, EGF, and STAT3, they share a lot of markers that we see closer to the stem cell layer of the bladder. And when we look at the very superficial lumen of the bladder, that's where we see PPAR gamma expression and FGFR3. So it might tell us a bit about the underlying biology of these tumors. So it's becoming increasingly clear that bladder cancer is complex with multiple tumor types, and perhaps that's why, with treating every patient the same way, we have not made the technological advances that we had hoped to do so in the setting of novel agents. Since we published this data, other groups of well have used gene expression profiling, again in this retrospective group of patients off clinical trial, showing a basal subtype in red really does the best when treated with neoadjuvant chemotherapy. So we can start to make predictions about tumor biology. And since then, we're really seeing an expansion in the different types of urothelial cancer, not only seeing this FGFR3 mutation cohort, but I believe there's probably a HER2 or ERB2 mutation cohort that's targetable, and there's early data now coming out suggesting activity of ERB2 targeted agents in urothelial cancer. Also from others, we're seeing these neuroendocrine-like tumors as well, along with the other subtypes. So when we start looking at the different types of bladder cancer, FGFR3 does appear to be a target, especially in that immunologically cold group of tumors. And I had the pleasure of leading development of erdafitinib with Janssen as we developed a phase 2 clinical trial to study this novel agent in the setting of urothelial cancer. And we were pleased to report that this was recently published in July of 2019 in the New England Journal of Medicine. When we look at erdafitinib, it is a potent inhibitor of FGFR3. It is a pan inhibitor of FGFs 1 through 4 with inhibitory concentration 50s in the single-digit nanomolar range. Early data suggested activity not only in patients with metastatic or unresectable urothelial cancer with mutations, but also in other tumors, including cholangiocarcinoma. At the time we were developing this agent, we had not yet seen an FGF inhibitor that could be given in a continuous fashion. So what we had designed was at first a randomized trial where we looked at two different doses, a continuous dose at 6 milligrams PO daily versus an intermittent dose of 10 milligrams daily, 7 days off and 7 days on. We ultimately, based on clinical activity and toxicity, we selected the regimen with continuous dosing. And with additional PK modeling, we actually found that with this agent, we were able to increase the dose to 8 milligrams daily, and then we up-titrated to 9 milligrams PO daily using target phosphorus levels as a surrogate for inhibition of FGFR3. When we look at the characteristics of patients treated on the second line and beyond trial, we do see over 50% had aggressive disease, more than 2 or 3 prior lines of treatment. Visceral metastases were present in 79% of patients. This is important to keep in mind as they're associated with a very poor clinical prognosis. We also saw a poor creatinine clearance or GFR rate in over 50% of patients, which is very common in urothelial cancer given that they're elderly, frail with comorbid conditions, and often have urinary obstruction contributing to poor GFR. At this time this data was presented, it really was one of the best waterfall plots we had seen in the second line setting for urothelial cancer, with an objective response rate of around 40% and 76% of patients having at least some reduction in the size of their tumor. We looked at a variety of variables on this forest plot to determine if any predicted better or worse outcomes. And what we can see, there is a sense that worse ECOG performance status was associated with worse outcomes, which has been shown clinically as well with other treatments. But we were gratified to notice that we saw similar activity regardless of good or poor kidney function defined by a GFR of 60 mils per minute. We also saw clinical activity whether or not a patient had more than one line of treatment, and we did not see any difference in objective response comparing visceral versus non-visceral metastases. And visceral metastases have typically been associated with a very poor clinical prognosis. We also saw evidence of activity in particularly aggressive patients. So I mentioned that we saw similar response rates in patients with visceral metastases, which prognostically has had poor clinical outcomes in the setting of immunotherapy and even in chemotherapy. We see a very low response rate in the setting of immune checkpoint inhibitors when liver metastases are present. And this is a patient that we treated who had very aggressive, rapidly growing liver metastases. And he had had several prior lines of therapy. He could tell that he was feeling poorly. His performance status was starting to decline. And he told me, you know, Dr. Siefker, I have young children at home, and if I'm not feeling better in 2 weeks, I am not coming back for additional treatment because I need to spend time with my family. And I actually told him, if you are not feeling better in 2 weeks, then don't come back. The treatment clearly isn't working, and it is time for hospice. But we had seen several other patients with rapid responses notable within the first 1 to 2 weeks, and this occurred with him as well. Within 2 weeks, he felt significantly better. And as you can see, even in this poor prognostic tumor with extensive liver metastases, we saw at least an 82% reduction in the size of his tumor. And although he did eventually pass from his urothelial cancer, he was very grateful for the additional time that he had to spend with his children. We also saw a gratifying progression-free survival of about 6 months and a median overall survival greater than 1 year. Keep in mind that the historical standard with chemotherapy, cisplatin in the frontline setting, was associated with a median survival of around 1 year. And now we were seeing this in a second to third line setting with an oral targeted agent, which is really something that we were very gratified to see in this patient population. However, as we say, there's no pain, no gain. Unfortunately, there is still toxicity. And we do see evidence of hyperphosphatemia, but keep in mind we were actually up-titrating the therapy to achieve a level of hyperphosphatemia with a phosphorus level greater than 5.5 being the cutoff for up-titration. We do see evidence of mouth sores, the hand-foot syndrome, and paronychias that you expect with these types of inhibitors. But overall, the grade 3 events were relatively low, especially compared to historical chemotherapy options. We did see a new class of drug effect called central serous retinopathy, and this is a known class effect of other inhibitors of the MAP kinase pathway. Others have suggested we should call this a MEK-associated retinopathy since it often doesn't have the fluid or serous drainage. It's typically seen with the diabetic serous type retinopathies. Patients were routinely monitored for this on the clinical trial, and even though we observed this in several patients, about a quarter of patients overall had at least some development of central serous retinopathy, it rarely led to discontinuation and was reversible with holding therapy. So the trial did meet its primary endpoint with a 40% objective response rate, a median progression-free survival that was very promising, and an overall survival of 13.8 months. It was very well tolerated, compared to the typical treatments that we had seen in the day, and we were able to up-titrate to 9 milligrams a day in nearly half of patients. On the basis of these results, FDA granted erdafitinib a breakthrough therapy designation of March of 2018, and more recently, in April of 2019, granted accelerated approval of erdafitinib for the treatment of an FGFR-altered metastatic urothelial cancer. However, we still have further therapies and studies ongoing, including a phase 3 trial called THOR, which compares erdafitinib versus chemotherapy or an immune checkpoint inhibitor. And we are also combining erdafitinib with an immune checkpoint inhibitor to see if this help enhances an immune response in this immunologically cold state. One question that had arisen very early was, do mutated FGFR3 urothelial tumors have greater benefit from a checkpoint inhibitor or from treatment with an FGF-targeted agent? And as you may recall, when we looked early, we saw evidence of FGFR3 alterations in this immunologically cold group of tumors, and there was early data suggesting checkpoint inhibitors had lower response rates in this group of tumors as well. This set of immunologically cold tumors, they often have deletions of chromosome 9 and also loss of the gamma interferon gene signature. We went back and looked at patients treated on the erdafitinib phase 2 trial and looked at investigator-reported response rates to prior immune checkpoint inhibition. And of the 22 patients who had received prior immunotherapy, there was only one response out of 22, and the response did not appear to be durable. The time to next treatment was approximately 10 months. When we look at the treatment to erdafitinib, or the response to erdafitinib, we saw an objective response rate closer to 59%, which lead us to wonder, could some of this be due to the presence of checkpoint inhibition still on board at the time they were receiving erdafitinib? Because when patients progress on a checkpoint inhibitor, they cannot wait several months to begin a next line of treatment. Oftentimes, their survival is poor and they will have already passed away. So trials have allowed patients to go on the next line of treatment without waiting for a substantial washout period from immunotherapy. And this is some of the early data that led us to try the combination of erdafitinib with the checkpoint inhibitor on the NORSE trial. More recently, we saw evidence that some FGF-altered tumors may indeed respond to immunotherapy, and this is data that was presented by Galsky and is now published in European Urology. He went back and looked at two clinical trials. One is the Checkmate clinical trial of nivolumab in second-line urothelial cancer, where in a very small number of patients, only 15, they saw 3 out of 15 patients respond. A slightly larger data set from INVIGOR-210, a second-line trial of atezolizumab, suggested a response rate of 21%. Unfortunately, he did not publish any information regarding the durability of these responses. So are they durable or not? And interestingly, each of these trials had enrichment for PDL high group of tumors. So it leads one to wonder whether enrichment for PDL1 high group could have somehow altered the biology or taken a group of tumors that still had mutations present, but now had PDL1 and other markers driving the benefit from treatment. So clearly, we need more data in this setting, and this is why the THOR clinical trial was designed to compare erdafitinib versus pembrolizumab in patients who had no prior immunotherapy, with the goal of determining what is the better treatment for this patient population based on response and survival. So there clearly is a role for FGF inhibition. It's a clear target in urothelial cancer. We see the presence of the mutation in metastatic urothelial cancer in tumors of the bladder. It's around 15 to 20%. In upper tract tumors, we see the presence of this mutation in over 35% of patients. There's also limited alternatives for metastatic and even superficial urothelial tumors. So this new class of agents has an alternate toxicity profile compared to immunotherapy and chemotherapy and could presumably fill an unmet need in the treatment of this malignancy. We still have several questions to answer, especially can FGFR3 inhibition potentiate the effects of immunotherapy by breaking this immunologically cold state? This is some data that we had developed with Woon-Young Choi and David McConkey while they were at MD Anderson. It was a phase 2 trial of vofatimab, which is an FGFR3 targeting antibody. And we gave this treatment with pembrolizumab in both wild type and mutated FGFR3 tumors. Unfortunately, the company lost their funding and we couldn't complete the full plans for the trial with larger cohorts of patients. But of the 19 patients who had a 2-week lead-in of the FGF targeting antibody, we were able to get pre- and post-biopsies tissues in about 19 patients. When we look at those patients who had partial response, we saw that the responders appeared enriched in this immunologically cold cluster, including in wild-type patients, and that the responders also had increased expression of genes associated with the inflammatory response. When we compared these different tumors using unsupervised clustering to determine subtype, much has been similarly been done in the breast cancer TCGA and bladder TCGA, we also looked at where these FGFR3 mutations were lying. Were they still being found mostly in the luminal, immunologically cold group of tumors, or did we see them in other areas? Keep in mind, this is a different biopsy site. We're biopsying metastatic disease, and the earlier TCGA data was developed from tumors in the bladder in early stage muscle invasive disease. And what we saw out of the 5 patients with FGFR3 mutations, only one appeared to be associating with this luminal immunologically cold group of tumors. So it has raised this question, will biopsies in the setting of metastases continue to suggest that these FGFR3 alterations are enriched in immunologically cold tumors, or do the patterns change over time or additional mutations develop? There has been early evidence that we can also shift subtypes to optimize the biology of these tumors. So the idea being, even if they're cold, can we make them warm to the immune response? Can we take tumors that are too hot, reduce them with chemotherapy, and make them respond better to other targeted therapies? So are subtypes fixed, or can we shift them? And there was early evidence that we can shift a tumor subtype or change the biology, which I think can certainly go along with a lot of the pruning studies that people like Dr. Linghua Wang are working on, understanding how these tumors evolve and change being treated with multiple subsequent therapies. This is going back to data from our neoadjuvant trials where we did gene expression profiling. And while we had seen that basal group of tumors had the best clinical outcomes when treated with cisplatin, we also saw evidence that we could take some of these colder tumors to the immune system and shift their subtype from this more luminal to, we were calling it P53-like. Now they're being called luminal infiltrated, but we see higher levels of immune markers present in these tumors. So perhaps that could be additional data suggesting giving combinations of chemotherapy with immunotherapy or even sequences of chemotherapy with an immune checkpoint inhibitor. And if we can see this in the setting of chemotherapy, perhaps we can do this with FGF-targeted therapy as well, as we saw from the earlier vofatimab data. So as we're developing our work in urothelial cancer, There's a clear sense that bladder cancer is no longer just one disease. We need to understand the biology of each of the different subtypes of urothelial cancer. Once we are able to choose the best treatment based upon individual biology, we can then understand resistant mechanisms of each subtype and target them even more specifically, leading to more rational combinations and sequences of therapy, and then realize our overall goal for that personalized medicine strategy where we are treating the right patient with the right treatment. And as I mentioned, I think there are subtypes within subtypes, and we are going to understand which of these tumors respond better to which inhibitors, and then target them more effectively by shifting subtype, by shifting between classes of agents based upon mutation patterns that emerge, and how we can alter the immune microenvironment. And I'd like to thank you all for listening and joining us today. And I would most like to thank all of my collaborators, because this type of work can't be done by one person. It really requires not just a village, but a whole city. And a special shout out to Dr. J.J. Gao, who's been essential in our development of strategies in the lab to help understand how FGF inhibitors will work, especially collaborators in his lab, Dr. Jianfeng Chang, Dr. Jenny Meng, who have been involved in a lot of our tissue studies. I'd especially like to point out a very young, but just so much expertise with Dr. Wenjiao Li. And she came from Dr. Giannicola Genovese's lab, and she's helping Dr. Gao build this animal model where we can understand how FGF inhibition impacts the immune response. And unfortunately, her baby mice went into the deep freeze, and it will take some time to bring this back online, but we're so excited to see the institutions start to open up so young investigators like Wenjiao can get back in the lab and continue to develop these models that I think will be pivotal in understanding FGF inhibitors. I'd also like to point out Dr. Alexander Andreev Drakelin, one of our MD Anderson fellows, who's a very promising fellow in the Division of Cancer Medicine, who received a Young Investigator Award from ASCO with planned projects in FGFR3. Other collaborators we're working with, again, Dr. Giannicola Genovese, Dr. Li Huang Wang, whose bioinformatics is phenomenal in understanding how we're going to shift between these different types of tumors. Even investigators from other institutions, David McConkey and Woon-Young Choi, who were part of our bladder spore program when they were at MD Anderson, and were really pivotal in getting me interested in the FGFR3 pathway. We also have our whole research team, and I couldn't include everyone. There are so many more people that are involved in obtaining tissues, getting patients on treatment, getting them enrolled on clinical trials, and doing all the monitoring. But in particular, I want to give a shout out to people in my clinic who've been essential in the care of these patients, especially as we deal with patient care during COVID and treat these patients on clinical trials safely and from a distance whenever possible to keep them safe from coronavirus. So a special shout out to Lydia Lopez, who's my right-hand woman in the clinic, Giomara, who works hard scheduling and rescheduling as we find schedule shifting, and April, my nurse, who is always on the front line returning calls. So I would like to thank all of you for your time, and especially thank all of my colleagues for everything they're doing for our bladder cancer program.
Thank you very much, Arlene. It was a wonderful presentation. It was clear, and it's clearly a nice combination between research and translational for the patients. And of course, I very much appreciate your words that this is a rough time and we have all the time to be very thankful for you guys in the clinic and for all the people who are now dealing with COVID patient, and of course to keep an eye on the fact that clinic without research is not moving forward. So we have to take care also for the scientists to restart their job, because each day from now on it's an important day, not only to do discoveries but much more to help the patients with what is new. And of course I will start with the question. So we have a question. Please, if you can detail a little more on the role of FGFR3 and its effects on tumor cell biology.
Well, FGFR3, compared to other inhibitors of pathways where they have more anti-proliferative effects, with FGFR3 inhibition, we not only see changes in proliferation, we also see definitive cytoreduction of tumor. So inhibition with FGFR3 causes cell kill. And I think that's what's made it particularly effective in the clinic. When you look at pan inhibitors versus more selective inhibitors, there's always been a sense in the clinic that the dirtier the drug is by inhibition of multiple pathways, the better or more likely you are to achieve a response. So I think one thing we need to learn with these FGF inhibitors is what is needed and what don't we need. Are there parts of the pathway that we should not be targeting due to toxicity? I think one thing that sets erdafitinib up a little higher from several other treatments is the fact that it is a true pan-FGF 1 through 4. A lot of the other FGF inhibitors are FGFs 1 through 3, and our understanding from looking at cell culture and cell lines rather suggests a game of whack-a-mole. If you inhibit 3, you see 1 go up. If you inhibit 1, you see 3 go up. If you inhibit all of them, you see other factors and other growth factors go up. So I think we need to learn how this works in patients, follow their mutations over time using circulating free DNA to see what other pathways are arising. But getting back to our laboratory colleagues, use their knowledge and their science and the models that they're able to build to find out how exactly this works, what are the mechanisms of resistance, and how can we best overcome them by bringing in novel agents or other targeted agents as well.
Your answer. And another question. So it's known that microsatellite instability, it's a marker of response to immune checkpoint inhibitors. What is the status of MSI and mismatch repair in bladder cancers? How frequent there are MSI positive bladder cancers, and if it is a screening for finding that probably few patients who really have this type of genetic anomaly?
Well, the use of microsatellite instability certainly does enrich for a group of urothelial tumors that are more likely to respond to an immune checkpoint inhibitor. And for example, I have a patient I'm treating right now on trial. She has a known Lynch syndrome. We put her on an immunotherapy combination. Her tumor has had a dramatic CR. But early on in her treatment, she reported difficulty swallowing. And sure enough, she had an esophageal cancer that was unrecognized. And we suspect that the use of immunotherapy drove immune cells into that tumor, causing symptoms. So we do see microsatellite instability and urothelial cancer. Both of her tumors appear to be in a complete remission as a result of immunotherapy. Checking for satellite instability is not required, likely because it's approved for all urothelial tumors, but we do see satellite instability. We see a higher rate of Lynch syndrome in the setting of upper tract tumors. So upper tract tumors is one of the Lynch tumors. We'd still see it in some of the bladder tumors at a lower frequency. So it really depends on the types of urothelial cancer that you look at.
One more question. How do you envision, let's say, 3 years from now, the therapy of this type of bladder cancers? Your presentation was very clear that bladder cancer represents a multitude of cancers, and in fact, personalized therapy is the future. But how did you see this type of therapy for this specific type of cancer?
So over time, I think we're going to see a greater reliance on markers, patients being tested for mutations, and the potential for mutations over time, especially as we start seeing gatekeeper mutations arise in the setting of treatment with other FGF inhibitors. We may see other mutations increase after we treat with an FGF inhibitor. We're seeing other targeted agents that are specific for certain mutations, including HER2 expression. So I believe over time we will be incorporating more of this personalized therapy. And it may become more like perhaps like a leukemia, where they know certain leukemias do better with certain sequences of therapy. So we may find that an FGF altered tumor doesn't do as well with immunotherapy, but does significantly better when we combine immunotherapy with an FGF targeted therapy. So allowing us to make those decisions that we choose a combination compared to a single agent. I think a lot of the trials that are ongoing right now will answer some of these questions, including Norse, including Thor, and so many other trials that are planned. And so during the time of COVID, I'm really hopeful that we can get the whole research program up and running, all the way from clinical trials to basic science, because we're going to need the whole team working on this to understand how to treat this, what models are needed in the future, and how to find targets for each of these different types of cancer.
And with this, thank you again for your time here, and I want to thanks to all the participants. Again, without the attendees, this type of webinars make no sense. I want to thank to all the speakers till now, wonderful presentation. I want to let you know that next week we have Dr. Anil Sood, Dr. Jeb Myers, and Dr. Yijing Gi on the roster. So to all of you, please be with us, large family of MD Anderson from Houston, from Texas, from all over the world. And again, keep in mind, after rainy days come sunny days, and certainly we will move forward stronger, because what we love more is taking care of our patients and doing science. So Arlene, again, thank you very much. Thank you all of you guys, and good luck. See you Tuesdays, same time, 10 o'clock Houston times. Thank you all, and have a fun day.